The topic given to me is, where does monotherapy, systemic monotherapy, stand? So why are we even talking about it when we have already established the standard of care? We are happy with the CRT for squamous, we are happy with perioperative chemo for adeno, then why the discussion of monotherapy in esophageal cancer? So we have not perfected the pre-op regimens for esophageal cancers. There is still a lot of scope we can, we can improve. The PAT-CR rates, despite all that we are doing, remain dismal. So we are still striving to get better. We are still striving, and as all of us are repeatedly discussing the wait and watch approach, we have not arrived there yet. So it's all in the process, and I would shortly show you. This is what is to highlight the current standard of care. And for the patients in squamous cell carcinomas post-CRT who have not achieved pathological CR, we are now giving them 1 year of nivolumab, but that's only for the squamous. Now, there are a lot of biases between in the data that we have for esophageal cancers. The most common cancers that we see is squamous, but the representation of the squamous is very low in the trials that we have adopted. Most of the squamous cell carcinoma data comes from the Japanese trials, and Japanese seem to be really interested in single modality treatment. So why are we even talking about the single modality treatment? Is it more effective? Is it less toxic? Is it giving us more OS benefit? So yes, probably to some extent, CRT has its pros and cons. CRT is more toxic, and post-op complications are more after CRT. The anastomotic leakages are more. Though it gives high PAT-CR rates, it is not translated into OS benefit till now. So probably for younger, fitter patients, a more intense chemotherapy or more intense systemic therapy might give higher PAT-CR rates, and CRT could probably be used for a lesser fit patients. I have nothing against radiation. Definitive CRT still has its role to play in medically unfit patients or patients who refuse surgery, and in the location like cervical esophageal involvement where we have no option but to give CRT. So I will quickly walk you through some of the data. We have already been through the MAGIC FLOT cross data. Let me walk you through some of more data which has directly compared CRT versus neoadjuvant chemotherapy. So this is all to show where we have arrived at. Earlier, surgery was the way to go, and then a lot of JCOG 9907 and meta-analysis established that neoadjuvant chemotherapy is the way forward. Then there is the NEORES data, which head-to-head compared CRT versus neoadjuvant, and it showed that CRT is not better than neoadjuvant. There is a combined analysis of JCOG 9907 and JCOG 9906, which also showed that neoadjuvant fared better than CRT with OS benefit. So this is another Chinese paper which also showed that though there was a CRT did give a numerical benefit, but that was not statistically significant. Now, this is the most important trial I would want to walk you through. This is the JCOG 1109 NEXT trial. This is Japanese trial. It was conducted across 44 hospitals in Japan, and they used a very different regimen, chemo regimen. This was a triplet, three-arm trial, randomized phase 3 trial. So they tried to look at whether doublet is better than, how would a doublet fare when compared to triplet or CRT, and the primary endpoint was OS. So obviously the triplet did better than doublet, and the CRT was not better than the doublet. So they were to look head-to-head CRT and the triplet regimen only if CRT would do better than doublet, but that was not the case. So if you can just look at the numbers here, the 3-year OS was highest for the triplet regimen, median OS not reached, R0 resection rates were comparable, PAT-CR rate was high for the CRT arm. But then the esophagitis was also very high for the CRT arm. Febrile neutropenia, as expected, was higher in the triplet arm. Anastomotic leakages were higher in the CRT arm. So though they could not, by the protocol, look for, compare both the arms, I mean the CRT and the triplet arm, there was a numerical benefit of OS in the triplet arm, and the CRT arm reported a higher non-cancer related mortality. So all in all, what is this trial trying to tell us? Triplet chemotherapy could also be an option for squamous cell carcinomas, though we automatically assume that CRT is there for squamous cell carcinomas. And because the pattern of recurrence, like Dr. Shikhar was saying, are different, it leaves a room for using radiation probably later on in the treatment journey. And definitely CRT has its complications. While we wait for an answer on that, there is more that is happening. We are now adding immunotherapy to chemo to achieve higher PAT-CR rates. These are early phase 2 trials, but it is promising. Now let's come to adeno. So for squamous, as of today, CRT is the standard of care. Maybe more data with chemo IO or triplet chemo, more intensification of chemos might give an answer to that. Coming to the adenocarcinoma, as was extensively discussed, ESOPEC has laid rest to the debate that neoadjuvant perioperative chemo is the way for adenocarcinomas. The ESOPEC data, clear winner, FLOT is the clear winner. And just walking you through the numbers, FLOT fared better when it came to the recurrence-free survival, median OS. Distant recurrence risk, of course, was high in cross. Local regional risks were high in FLOT, and that is why probably we could salvage them with the radiation later on. Yeah, the toxicity was slightly better in cross given the intense regimen of FLOT. Matterhorn, this is just to say that we are more intensifying the perioperative treatment to achieve higher PAT-CR rates. But so can we do away with chemo also, or even surgery? Like time and again, we are talking about wait and watch approach. Probably this will be for a very small percentage of patients. There is some data of IO-IO combination, though it is only phase 2 data. And we are not, whether or not we can, I think the answer is not clear yet. There is phase 2 data of using immunotherapy alone, IO-IO combination in MSI-high tumors, where the PAT-CR rates have been to the tune of 50 and 60%. And as a matter of fact, it is already in the part of the guidelines, that is MSI-high tumors, when we are giving them either immune checkpoint inhibitors or neoadjuvant chemo, if at all there is no evidence of disease, we could probably subject them to observation. So the scorecard pretty much looks like this, whether when we compare CRT versus systemic therapy alone. I think we don't have a right answer now. So the current position of systemic therapy alone, we still don't know the answer. Probably for young, fit, resectable disease, we should go for systemic therapy alone. And because CRT, though it gives higher PAT-CR rates, it has not translated into OS benefit. Here, I think we are heading towards organ preservation as more and more data comes. Thank you.